All right. Well, welcome everybody, and welcome back to our seminar series at the Prevention Research Center. So we're excited. This is our first seminar for the year. As everybody knows, this is a monthly seminar. It is going forward now. It is being supported by the School of Medicine and the Angela Bowen Williamson Endowment. And so we'll stay here at the same times. We have pretty close to being the year's done. Close. How many more? If anybody has any suggestions of a topic or a person locally, regionally, or nationally that you'd like to see present here, please let Suzanne know. I think we do still have a couple of slots in the spring. The struggle always is how do you find people in February, March, and January, like when, especially now that we know we're going to have this horrendous winter. Yeah, right. So if you haven't signed in, there's a sign-in sheet at the front. If you're new to this, I think most people have been here before. The bathrooms are right around the corner. If you want to live tweet, it's hashtag PRCHN seminar. Did I leave anything out now?
I think that's it.
Okay. So I am extremely pleased to introduce our first speaker for the year, Dr. Brittney Soler. This has been a personal endeavor for both of us. We've had an exciting, really, 2 days. Those of you that know, our relationship's kind of an interesting one that came about, in particular of our joint interests. Those of you here know what this interest is for me, which is that we ended a 7-year NHLBI study as a null finding. Right? We spent 7 years working with 360 families here in Cleveland, had a 92% follow-up rate. The families thought the intervention worked very well, and the intervention had no impact on BMI. It was a study of 360 families where the child was at the 85th percentile or higher. And if you came to that seminar I gave, we were one of 4 sites across the country aimed at this, which was aimed at low-income families, and none of the sites had an impact on BMI. So before we invest more, we need to step back. So simultaneously when this happened, Dr. Schuler and I met at the American Academy of Health Behavior last year, and come to find out that she's very interested in this whole concept of the adversity. But what is this adversity? What are we talking about? In our space, we often say what? Well, it's the social determinants. They're bigger than we can, what are we going to do with it? And like, how do you unpack that? And it was extremely exciting to hear Brittany start to articulate these concepts of how are we going to dig in, figure out what the issues are, and then to act upon them. And so we had a lovely couple of days really working through a lot of good ideas. And today, I'm very excited that she's going to present a model that she's been working on. So Dr. Schuler started her career as a social worker. She has her BSW and MSW from Temple in social work, followed by her PhD in social work at the University of Maryland, Baltimore campus. And then lastly, and where did I see the Michigan hat a minute ago? Did you have a Michigan hat on? Is that a dem hat? Did her postdoc at the University of Michigan at social work, and is now an assistant professor back at Temple in the Department of Social Work in the College of Public Health. And so today her topic is looking at a new framework of understanding the childhood obesity in the context of adversity. And so we're both hoping that we're going to hear a lot of interaction too of once you see the model and giving sort of feedback on what some of the steps are in her work, but also how could we begin to integrate some of this work here. So without further ado, welcome Dr. Schuler. Thanks for being here.
Thank you. Thank you so much for the introduction. I'm very excited to be here. It's also my first time in Cleveland, so this is very special for me, and it's been great so far. And I'm really excited to be here to talk about some of my work and some of the future directions of where I see it going. And so, like Elaine said, we've had a couple of days to really try and, often when we talk about this, really trying to dissect and get to the bottom of what's going on in this world. And I, have long been interested in social determinants and social determinants of health, and, particularly how they map onto early markers of risk. So, nutrition and nutrition-related disease, it's very important to think about diet and nutrition early on in childhood, because that can map onto so many types of chronic illness, including obesity, longer term. And so, I've always been interested in, how we can look at these social determinants to interrupt these early markers of risk in early childhood. But from my social work background, I, have had a lot of time in under-resourced communities and working with families that have a lot of risk and not a lot of resources, living in extreme poverty. And in this work, I think a lot about how on earth can we help families do this when I think about myself, someone who has some resources, and I can go out and buy things and access things and even staying healthy is hard enough for me unless someone's handing me a nice healthy rat for lunch, right? So I think a lot about how can we improve health and health disparities in low resource communities in ways that are feasible and practical, and how we can really help support families. So today I'm going to talk to you a little bit about some of my preliminary research in this area and the framework that I'm developing and working on testing to try and get a better sense of the environmental context and what adversity really means and what hardship really means for families, and thinking about how we can really start to develop interventions that are going to help families in this area. So just a little background on obesity, if this isn't everyone's particular area, but it's a big issue. 19% of U.S. children have excess weight. These rates are particularly high among our lowest income groups and racial and ethnic minorities. Where those interact, health disparities are extremely high. And rates, particularly in early childhood, have more than doubled in the past 4 decades. And so some national research in the last few years has come out and shown these trends start to decline a little bit in the last few years. But if you think about the grander scheme of things and the last few decades of how these rates have really continued to increase a whole lot, this is still a really big issue that we need to pay attention to. And there are, for reasons of all the costs and consequences that come along with having excess weight and having poor nutrition. So there's immediate risk in childhood causing psychological distress and mental health issues, peer issues, bullying issues, and effects on your physical health starting as early as childhood, on high blood pressure, high cholesterol. Now these effects are going to persist and increase your risk for morbidity and mortality, long-term chronic illness, things like type 2 diabetes, cardiovascular disease, and increasing research is linking excess weight to an increasing number of cancer risks. Not only that, the economic costs of these health conditions are really high. So estimated $147 billion in medical costs associated with obesity, $245 billion associated with medical costs and loss of productivity, when people can't work, associated with diabetes. And these are just diagnosed cases. So obesity is a very complex problem, right? We think about our ecological model. There's a lot of levels of influence that can increase a person's risk for having excess weight or being able to lose weight. This includes genetics, metabolism, the environments, what's around. Is it do you live in a food desert or a food swamp? Is your neighborhood walkable? Is there access to recreation? Is the neighborhood safe to walk around? Is there a lot of crime? Health behaviors, what are dietary patterns like? What are mealtime patterns like in the household? What are families' patterns and styles around eating together or not eating together, around shopping and planning for meals? So poor nutrition is a pretty significant contributor to obesity and a number of other chronic illnesses, like I said. So nearly half of all Americans have a preventable diet-related disease. This is pretty high. And this is really attributed to trends in overconsumption, where the number of calorie-dense snack foods, foods with added sugar, foods with added fat, things that are disproportionately consumed by kids, that are very palatable for kids, where they're getting almost 27% of their energy from these empty-calorie, high-fat, high-sugar snacks, and these trends in overconsumption of these foods are increasing. Along with failing to meet recommended dietary recommendations from the USDA, how many fruits and vegetables they should be eating on a daily basis, and having way too many foods high in sugar and sugar-sweetened beverages and things like that. So nutrition is particularly, like I said, critical in early childhood, where a lot of the dietary patterns and eating habits that we have early on, they're established in childhood, and we usually carry those through into adulthood. A lot of the styles, if you think about ways of modeling what parents are doing and how parents are eating, these are things that kids pick up on. And so, the recommendations are that kids should have between at least 3 to 5 servings of fruits and vegetables every day, and really be limiting excess sugar and added fats. But this is primarily not happening. This is an issue particularly in high poverty areas. So where I'm from, in Philadelphia, particularly North Philadelphia, where Philly has one of the highest poverty rates of all major U.S. cities. North Philly is one of the poorest areas in Philadelphia, where Temple University is situated. And here the estimates are that 25% of youth get 1 serving or less of fruits and vegetables per day. So really below what's recommended. And that approximately 70% of kids are overweight or obese. It's nearly double the national average. And so in places like Cleveland and other major cities where you have a high poverty rate, these types of statistics are not going to be very different. So what things have been done to address this obesity crisis and to improve health and improve nutrition? So, a lot of this work is also inspired by my conversations with Elaine and this talk about what happened with the impact study, and also a ton of other systematic reviews on obesity trials and obesity prevention interventions that are coming out with the same results. Particularly when you narrow this to looking at high-risk, under-resourced communities, where there are a lot of evidence-based strategies for improving health and reducing excess weight in the broader population, but when you focus that in on high-risk communities without a lot of resources, those effects get washed out, and it's hard to maintain the sustainability of those effects over time. And so these null findings are really attributed to the extreme levels of barriers that people face when living in a high-risk environment. So, as I said, we know about, the built environment, that not having access to quality foods or living in a food desert and not having a grocery store is a contributor to how people behave and, health promotion or the lack thereof. And but actually, there's some interesting research that came out on food deserts where they had built grocery stores in a food desert, and then they looked at trends in diet and are people shopping more? Are they eating healthier? And they found no effects, because it turns out, you can't just put a new thing in a neighborhood after decades of not having these resources and expect people to just use them and to change what they've been doing every day for the past, however long that they've been living there. So on top of that, in the built environment level, in the community context, families who live in high-risk environments, high-risk meaning, under-resourced and economically depressed, not a lot of job opportunities. There's also a lot of violence. There's also a lot of trauma. There's also a lot of crime, maltreatment. In these high-stress environments, you're going to get a lot more adversity, and disproportionately so. Not to mention the constraints on transportation barriers. When you don't have a car, it's a lot harder to get to the grocery store. You have to carry these things. You have to pick up your kid from one school and then another school and then go to work, and then you add all the time for waiting for the bus, or the bus doesn't show up. So you think about how this seriously constrains your time, especially if you're a single parent and you have a few kids, you have not a great social support system, you don't have family members to rely on, you're doing all of these things on your own. When on earth are we going to, how are we going to ask parents who are in these situations to cook and then to go food shopping and to add more kinds of chores to their daily lives, right? And then on top of that, they're negotiating very scarce resources, right? So you've got some money for food, you've got some money for bills, and a lot of months people have to negotiate whether they're going to pay their rent, whether they're going to pay their electric, whether they're going to pay their water, and what is going to be the most important thing. And so, if there are resources like being able to go to a food pantry or being able to use your SNAP benefits or finding food donations in some ways, which are usually limited to processed foods and packaged goods and that sort of thing, not fresh, whole foods. That's where families can sort of save money and get food cheaper and get those overly processed foods that are more empty in calories and be able to pay so that they can keep their electric on that month, right? So things like that are common. In addition to the lack of positive supports, when your family members also need resources and you don't have a large social support network where when you need something one month or you're running a little short or you need help with the kids, a lot of these resources aren't available, and there's not a huge, strong, positive social support network. So thinking about obesity in the context of adversity, as I'm talking a lot about how adverse circumstances you can start to see how they really obstruct our families or people's abilities to uptake some of the recommendations that we make in our behavior change and obesity prevention interventions, and thinking about asking families to set goals and think about meal planning and things like that. And so I think for me, one of the major limitations in obesity prevention research is really understanding the role of family adversity and the community context on obesity risk and eating behaviors in early childhood. So, where we know that there's a linkage and an early life adversity leads to poor health outcomes in adulthood, what are the mechanisms linking this? What are the reasons why this happens? And what are some of the early markers of behavior change and family dynamics that we should really be looking at here? So, some traditional definitions of adversity. Most of you have probably heard of the Adverse Childhood Experiences Study, the seminal study out of back in 1998 out of Kaiser Permanente, where they kind of said, well, these kinds of 10 to 12 items seem to increase risk for these health outcomes, and people seem to have a different trajectory, and we should really pay attention to this, right? So these are things like abuse, emotional abuse, physical abuse, things like household challenges, like having a household member who has a substance use issue, who has a mental health concern, if there's incarceration or intimate partner violence, things like this. So there'd be like 10 specified definitions of adversity. And so where, in my work in social work, I've seen these things in the field. I've also seen a whole lot more, right? I've seen a whole lot more ways that stressful environments and adversity in the community can play out in a lot of different ways. And so, thinking about this sort of model of what links adversity to our, morbidity and mortality, and where are the gaps in our understanding, is that we really don't know a lot about how adversity shows up to affect the social and emotional development of kids early on, how that affects the cognitive development early on, and then how that then links to the adoption of these early healthy risk behaviors that will eventually lead to chronic illness and excess weight. And so I started asking, what are these links, and what are some of the early markers and the early risk factors, and does adversity link on to early risk rather than just what we know about longer-term health outcomes in adulthood? And so this is my first study to start diving into this and see if there are some pathways and some associations. And so I first wanted to know, how do adverse childhood experiences associate with dietary habits in early childhood? And I wanted to know, for those of you familiar with the ACEs study, they really look at like your cumulative score. So the research shows that if you have 4 indicators, 4 ACEs, you're far more likely to have these adverse health outcomes. And so I wanted to look at the cumulative effect of ACEs and just looking at the count. And I also wanted to look at them individually. How does individual exposure to certain stressors affect these risks? And I'm really interested in health disparities, so I want to be able to compare, how is this different in a higher socioeconomic context versus a lower income context. So I use the data set Early Childhood Longitudinal Study. This is a large national data set representative of kids born in 2001. And so we looked at data from when kids were 9 months old, 2 years old, and 5 years old. So there's a combination of parent surveys that used to collect and look at daily servings. So the outcome were daily servings of healthy and unhealthy foods. We looked at fruit and vegetable consumption, sugar-sweetened beverages, and sweet snacks. And then for, what the ACEs measures were included in this data set included 5 different ACEs. So not the whole battery of them, but so specifically looked at domestic violence, substance use, mental and emotional distress, divorce, and incarceration. And so I looked at whether or not they had exposure to no ACEs compared to 1 ACE compared to having 2 or more ACEs. And then also looked at them individually. And so just looking at the prevalence of exposure to adverse childhood experiences, when I look at this in the full sample that represents everybody, there's about 12.5% of people have exposure to 2 or more ACEs. Okay? Then when you break this down and stratify the sample by low SES compared to high SES, you see that this number jumps up to 19.2% of kids in the low SES group have at least 2 or more experiences with adverse childhood experiences. And when you look at this in the high SES group, that goes down to almost 6%. So you see a huge difference. And for me, if there's other researchers in the room, one of the kind of lessons for this for me was, we look at this stuff in the national sample, we try and generalize our results and apply this to, the whole country. Really, it's missing out on, and I think that including everyone really dilutes some of the what's really going on in these data sets when the circumstances are much worse for people with lower incomes. And I think that's really important to think about. So then I looked at the cumulative ACE score and whether or not it predicted fruit consumption. And so basically found that in the full national sample, we've got a significant increased risk of lower fruit consumption for people that are exposed to 2 or more ACEs. Or even, that should be 2 or more ACEs. And then in the low SES sample, the decrease was even higher. So you see that the parameter estimates are even stronger for those in the low SES sample, where they were consuming a significant lower amount of fruits. And then in the high SES sample, this wasn't significant at all. So again, you see when you kind of stratify and look at these in specific SES groups, that there is a difference in how the results are coming out. Now, the cumulative ACEs were not associated with consumption of vegetables or the sugar-sweetened beverages or sweet snacks. It was only associated with fruit. So even though, these are not huge drops in daily consumption of fruit, these are not a huge amount of your daily servings in relation to the amounts being served. Overall, kids showed lower than recommended levels of fruit and vegetable consumption, and really it's not going in the ideal direction. So we're starting to see some associations come out here. So then I broke it down, and I looked at each ACE individually, and I really wanted to know, how these might specifically map on to eating behaviors. And I looked at it in the low SES group again, and the high SES group. And so as you can see here, those that had exposure to domestic violence were significantly more likely to consume more sugars, so more sugar-sweetened beverages and more sweet snacks in the low SES group. And this also held in the high SES group, where people exposed to domestic violence also had a significant higher risk of eating more sweet snacks. Okay. And then both substance use and incarceration affected healthy food intake, where substance use predicted a significantly lower amount of fruit and vegetable consumption. Incarceration predicted a significantly lower amount of fruit consumption, and this was only true in the SES group. So I think what's important here is that that there are stressors that are relevant for everybody across the population, where exposure to trauma and adversity can really affect these early markers of risk for kids as early as 5 years old. And that's across the board, but that, what I think is happening and why there's a lot more indicators in the low SES group, again, is that there's a higher prevalence rate of exposure to these adversities in the lower SES group, and that being in a higher SES group, you might have more protective factors that kind of shield you, buffer you from, not that these things don't happen across the board, because they do, but maybe there's some other protective factors that are kind of balancing out and protecting kids in different ways. So, for me, I think that this study really shows that there may be some shorter range effects of adversity on early markers of obesity risk, right? So we're starting to see some of the potential pathways that this could be operating through. But it is not very clear to me why these specific types of adversities would map on differently to healthy and unhealthy eating behaviors. I think that there's a lot more work to be done in that area, but overall we're seeing trends in lower quality diet and lower than recommended dietary practices. So I thought a lot about why these specific types of adversities would cause stress in early childhood, why they would map on to dietary risk, and I wondered what else might be going on in the lives of families based on my experience and my work, and I think that some of these definitions, like I said, of adversity, they can be limited, where families who are living in high-risk settings can experience a lot more different types of adversity, even on a day-to-day basis. And so, what is really the bigger picture of families who are living in this type of context? And not only that, but what are the pathways that link adversity? Like, what are the reasons that adversity and these stressors are linking to changes in diet? And how should we really be measuring adversity in this context? So I did another study, and I really wanted to, my idea here is, what does adversity really mean for these families? And so I wanted to look at dynamics of economic hardship or material deprivation, and does this sort of have similar pathways as our traditional definition of adversity? And so really building on family stress theory and family stress models that recognize that especially financial stressors can have an effect on parenting distress, mental and emotional distress for the parent, can affect parenting dynamics to ultimately affect adverse child outcomes. Now, most of the research using family stress models has primarily centered on behavioral and mental health outcomes for kids. And so I was really interested in how can this model apply to help us understand stressful environments and physical health disparities. So I looked at whether or not economic hardship predicts child diet quality, and whether or not economic hardship operates through parenting stress to predict child diet quality. I looked at this in a couple of ways. So, just to give a little bit of background, the research does clearly show some associations between economic hardship, or SES, and increased risk of obesity, increased risk of having a lower quality diet, less frequent family meals, those sorts of things. And also, poverty-related stressors are linked to less responsive parenting, and higher parenting stress and strained family interactions, poor child development outcomes. So we see these different pathways. We haven't looked at them all together. So I looked at the Fragile Families and Child Wellbeing Study, which is a longitudinal data set. We collected data from moms recruited from hospitals when kids were born and followed them until the age of 15. And they oversampled. This is a high-risk sample, meaning that about 60% of the families in this sample were living at 200% of the poverty line or lower. So here's some demographics for you to see. But you can see that most were non-Hispanic Black or Hispanic. Only about 21% were non-Hispanic White. And about 60% had a high school education or lower. So this is sort of what it's defined as this high-risk population that they oversampled unmarried families. And so I looked at economic hardship by looking at 8 different indicators of economic hardship. So, and I looked at this from longitudinally from between the ages of 1 and 9. So it was measured when kids were 1, 3, 5, and 9 years old. And I wanted to look at the trajectory of hardship over this time and do changes in material hardship during this stage of life have a association with risk when kids are a little bit older, when they're 9. And so economic hardship was measured by asking about things like, do you have food security issues? Do you get free food or meals? Are you unable to pay your rent or mortgage? Do you have trouble paying your bills? That sort of thing. Then I looked at parenting stress, was measured by asking parents, really looking at the level of distress they feel in relation to their day-to-day parenting. So, for example, being a parent is harder than I thought. I feel trapped by my responsibilities as a parent. I often feel tired or worn out or exhausted from raising a family. And then I looked at child diet, particularly in terms of calorie-dense snacking and added sugars. So I looked at the number of servings a child consumes on a typical day of candy or sweets, of snack foods or chips, and of soda. So the higher values here are going to indicate higher consumption of these foods. So here's a really complicated model that I came out with that I'll walk you through. And so I looked at economic hardship in 2 ways. So I did, if anyone's statistically inclined, I did latent growth curve models. And so if you want to talk more about the mess of that, we can talk about that afterwards. But basically what that does is it helps me look at the change in economic hardship and a family's trajectory in economic hardship over time. So does their hardship increase? Does it decrease? And does the way that their exposure to hardship and the way that that changes, does that predict diet quality? Is that mediated by parenting stress? And so I also look at, the very top, very top circle, we look at the average starting level of hardship. So what is someone's baseline measure of economic hardship? So we look at that, and then we look at, this is a quadratic model, just fancy stats people in here, but basically you want to look at this top circle, which is their average starting level of hardship, and this bottom circle, which is measuring their change in hardship over time. And so what I found was that their change in hardship between the ages of 1 and 9 was not predictive of parenting stress. But the average starting level of hardship at baseline when kids were 1 significantly predicted higher levels of parenting stress, which then significantly predicted lower quality diet, so higher consumption of the sugary foods and sugar-sweetened beverages. This is controlling for race and education. So where there's initially direct effects of economic hardship on diet quality, once I add parent stress to the model, those relationships go away, and you see that hardship and the starting level of hardship from age 1 is operating through parenting stress and child diet 9 years later. So you really see how the early exposure to hardship matters, and makes me think a lot about what if this is predicting things 9 years later, but we're working with families who have a high level of adversity. In what ways can we intervene, and what can we think about to do to help support families this early on when we're talking about healthy risk behaviors that won't come out until many years later? Right, so I made these circles for that reason. Okay, so you see. Proud of my animations. All right. Forget to use them. So yeah, like I said, interpreting this is the research it does is consistent with the existing research on this, where there's documented SES disparities in obesity, and there's a direct relationship between SES and increased risk of obesity, and that adding this parent stress model and a family stress model and seeing how parent stress really plays a role, looking at the baseline effects on what's happening 9 years later, and really expands our understanding of the physical health-related outcomes and the disparities that are really important in thinking about the context of adversity and how that plays out in family dynamics, especially when we're thinking about early childhood. So that brings me to what I'm working on now. There have been a few other studies where I looked at similar models and different parenting risk factors like parenting style, overreactive parenting, lax parenting, and parent mental health. And all of these things are consistently mediating this relationship. So it's really telling me how much family dynamics and parenting plays a role. And so seeing these links from economic hardship to parent stress and diet quality really made me wonder how forms of economic hardship are going to operate through similar pathways as adversity. So we have a lot of interventions coming out, evidence-based practices around trauma-informed care, and those really speak to a lot of our traditional definitions of adversity. And I'm wondering, do we really need to establish more of a wider definition of adversity and think about adversity-informed care in the context of not just traditional definitions of trauma, but really how economic hardship and chronic instability in that form can affect families. And so, I think that my preliminary work in this area is kind of showing links from both our traditional definitions of adversity and economic hardship to these early risk factors, and really left me wondering, how should the adversity context be defined? Are we defining this in the right way? And we saw how economic hardship can affect parenting stress, but what do we know about how this affects child development and the development of social and behavioral factors for kids? And really, what are the mechanisms of action? What are the pathways that things are going to operate through, and what are the targets what targets should our interventions be focused on? So there's a framework that was developed by a psychologist out of Harvard where she looks a lot at adversity and how that maps onto early childhood development. And so, our traditional definitions are developed based on just these 12 indicators that we saw that have kind of come out in some of our big research studies. And so what this researcher hypothesizes is that adversity is not so simple. There's multiple dimensions to it, and different types of adversity are going to affect kids in different ways. And so she hypothesizes these two different dimensions, right? There's the threat dimension, which is harm or threat of harm. This is going to be a little bit more consistent with our traditional definitions of trauma as per the DSM, like child maltreatment, exposure to violence. The second dimension that she pulls out is deprivation, where she's saying it's basically the absence of needed resources that one would expect to have in their environment. And so she moves neglect to this dimension where there's this expected, interaction with the parent that's not happening. Things like food insecurity and poverty. So she's saying that these two dimensions are going to operate differently to affect child development. And so, taking a look at these, a little closer look at these dimensions. Adversity has been linked to impairments in self-regulation in childhood, more generally. And that self-regulation, I'll talk about in a minute how that maps onto obesity, but adversity does have an effect on the development of executive functioning and self-regulation in early childhood. But it does so in different ways when you break down these dimensions. So what this researcher found was that threat links to deficits in emotion regulation and reward response, which are aspects of self-regulation. Deprivation, on the other hand, is going to map on to deficits in cognitive control, ability to delay gratification, and impulsivity. So we start to see how these different dimensions of adversity are affecting child development in some both affecting self-regulation, but different components of it that can be predictors of kind of how people behave and why they make the different health decisions that they do. So when we think about self-regulation and obesity risk, a good amount of research has documented how self-regulation plays a role in increasing obesity risk. So self-regulation and calorie intake are associated. More generally, so also the state of research on self-regulation in the child development world is a little bit different from the way that it's operationalized in the obesity world. And so this is going to be one of the challenges in trying to figure out how these components all fit together and coming up with figuring out what are going to be the most important components of child development and self-regulation that are important here. But basically, in relating to eating, decisions around making decisions around what you're going to eat that day and healthy food choices requires self-regulation, self-control. Making a decision about to stop eating once you feel full, that also requires self-regulation. Eating something when you're not hungry, if anyone had lunch before they came here and then also had lunch or another cookie, and you're like, I'm not really hungry, but this looks tasty, that has to do with your self-regulation and your self-control and your ability to, do you want to save that cookie for later? Did you put one in your pocket and you are eating one now? So, that's your ability to delay gratification, right? So these things that we can all relate to. But these are things that the adversity literature is saying that the exposure to adversity and hardship early on can really affect your ability to do that. And so the obesity research in relation to self-regulation shows links from, impulsivity, where you can see people who have the tendency to be more impulsive are less likely to have that control over saying, no, I don't want to eat that now, or I want to eat that later, or I've had enough. And they also tend to have people who have the effect on reward sensitivity, where eating something could feel extra good for somebody who has issues with reward sensitivity, where adversity affects your ability to respond to rewards and to external cues in your environment. And so you can see how it would affect your ability to kind of control and start regulating your eating. In the context of early childhood, these types of behaviors and self-regulation are just starting to develop. They don't become fully developed until you're 20 years old, but a lot of the things that happen early on are going to inform that development. That, along with, parents play a huge role in this developmental stage. But as I said earlier, kids between 2 and 5, the eating habits that you establish now, they're going to be carried on. And so depending on your parents' level of self-regulation and what kinds of behaviors that they're modeling in the home, all those things are going to come together to affect the child. And so self-regulation depletion theory is the idea that that you have a certain amount of self-control and self-regulation in a given day. You know, you wake up, it probably also depends on how well you slept, or, you know, how you're waking up, but how you wake up, you have some degree of self-regulation and some level of self-control that you can kind of muster through the day. And so if you can imagine a day when you've got like one stressful thing after another stressful thing after another stressful thing, you get home and you just kind of like flip out on whoever's in front of you because they're just in front of you, or, you know, so you see that these things can be wearing on you on a day-to-day basis. So then think about living in a very stressful environment, a very high poverty environment, lots of crime, lots of, you know, a lot more stressors on a day-to-day basis, and think about how this could really deplete your self-regulation capacity. And so I think this is another important thing to think about in a larger context of adversity and where people are living. So, yeah. So, adversity and obesity risk. So, as we know, that the research does consistently show that there are more that adversity is linked to poorer health outcomes. That this is the mechanisms that this acts through is that there's the activation of the stress response system. That this is linked to behaviors like overeating and higher BMI, and even changing metabolisms and inflammation and those sorts of things. So there's you do see a direct relationship in a lot of the research on this area. And so I'm going to add one more thing to this theory on the different dimensions of early childhood adversity. So, where children in elevated risk communities are facing unique challenges in relation to their exposure to these types of adversities. And I want to expand where the primary theory is saying that there's two dimensions, there's threat and there's deprivation. And what I think needs to happen is really an expansion of the way that we're defining deprivation, where the original conceptualization is that there's an absence of needed resources. And so if anyone works in a low-income community, you know, it's not just the absence of needed resources, it's the unstable or inconsistent access to these resources. And what it feels like to not know if you're going to have what you need when you come home that day, and that living in constant instability and an unstable environment can affect kids and people in the same way as just not having those resources at all. So where you know, absent resources, or, you know, think about exposure to child neglect. You know, neglect might not happen, the child might not be neglected 100% of the time, right? There might be some attention from the caregiver, and there might be some warmth sometimes. It's the fact that it's unknown and it's unstable that affects a child's ability to have and form secure attachments with their caregivers. It affects their ability to feel safety. That creates that level and degree of uncertainty. So I think a lot about how elements of deprivation or economic hardship can kind of operate through very similar pathways, in that, you know, think about having unstable housing where you're constantly hearing mom or dad talk about, I don't have enough money to pay the rent, or the landlord is threatening to evict us, or the water gets shut off, or the electricity gets shut off, or that happens, you know, somewhat irregularly throughout the life course, or even throughout the year. Having inconsistent access to food. And so how these levels of inconsistencies, based on family stress models too, where we know that kids are affected by their environments, they can see their parents stress, their parents are affected, and because their parents are affected, then they're affected by living and feeling the effects of these stressors. And so I think that this degree of inconsistency and unstable access can really affect kids' abilities to feel safe and secure, to form ability to regulate their own stress and to adapt and be more resilient. So I think that these are all really important components in kind of understanding the adversity context, and really kind of teasing this out to think about how these dynamics can operate differently but similarly, right? So we don't actually know a whole lot about how adversity, these pathways that they affect them. So, you know, like I said, there's been research that has linked adversity to poor health outcomes. There's been research that's linked adversity to impairments in self-regulation. There's even been research that has looked at these different dimensions of adversity and how they link on to self-regulation. There's been separate research looking at the pathways from self-regulation to obesity risk, how it affects diet, eating habits. But there's been no research that really ties this all together in one model and looks at how these different pathways intersect. So that's where I'm going with this. This is what I think is important here. And so not only that, but really pulling apart the dimensions of adversity and how they're going to differentially operate, and really thinking about living in a high-risk, under-resourced environment, what's really going on for families in this context, and how does that serve as a form of deprivation that we aren't really measuring yet. So I'm going to do this again, but sort of in a bigger way, where I think that, again, we think about an ecological model, that this is not all-inclusive, right? This might be one piece of the picture, where, parenting stress and parent and family dynamics are going to be an important role, self-regulation is going to be an important role, but what's really going to be important here is really understanding the dimensions and dynamics of adversity, how they affect families, how they affect child development, and how then that will map on to early markers of health risk for kids. Another important component of this is really understanding the development of self-regulation, where this is really, there's not a whole lot of research, particularly in the early childhood stages. There's a disconnect between the child development research and the obesity research, and how we're defining self-regulation and what we think the important components are. So we really need to, and these are just a few of them that we know are linked to, impulsivity and reward sensitivity, that we know are linked to obesity risk, but there are a lot of other dimensions of executive functioning, self-regulation that could increase risks here. And so we not only need to know a lot more about that, but thinking about the intergenerational effects of parents who grew up in similar environments, how that's affected their self-regulation into adulthood, and then how that affects the home environment, which are all going to be important components for kids. So in addition to that, we have to think about the community context and other community level factors and the built environment, and access to food and these sort of practical things when thinking about the context of where families live. And also thinking about what the protective factors are. So what are the things where everyone who lives in a low-income community does, and everyone who experiences some forms of adversity, not everyone ends up having excess weight or issues with chronic illness. But some people do. So what is different about those two groups? What are the protective factors that help kids adapt to these and cope with living in an adverse environment? What are the community supports, and what are the types of family assets and strengths that we can try and pull on and build on to help build up communities, and start thinking about systemic levels of ways of protecting families from the community level. So my thinking is that the behavioral interventions that we're developing right now, just for broad populations, are going to keep having some significant challenges and showing any effects unless we really think about what this adversity context is like, how we can really intervene to help support families, how we can incorporate supports for these different dimensions and dynamics of adversity to help support families, and how can we start incorporating these things into our interventions that are really going to help support families. How can we think about these dimensions of adversity so we can really understand the experience of families and how these issues are really conceptualized for families themselves, and how can we think about the key contributors to self-regulation. And so, and this is a quote from an article I really like, but basically it says that, and this is consistent with some of the interviews that I've done with parents, is that parents care a lot about their kids' health. They really do want their kids to be healthy. They really do want to feed them well, and they do make a lot of efforts to do that. They also have a lot of barriers and challenges to do that as much as they want to. So, in my thoughts about developing interventions, how can we help families make this easier without giving them more work to do? How can we help facilitate them meet their goals, for their families in the context of where they're working with? And I don't actually have those answers yet. But, I think that this framework is going to be a good starting point for thinking about some of the key elements that are important in helping us tease out what's most important for our interventions to focus on, how it affects families, and what our intervention target should be, and how we can start pulling out those strengths.
Good job.
There it is.
All right, we have a few minutes. Can you go to 12 or 12:15? I don't remember. So we have like 20 minutes or so. Good. Sorry.
So if there's any general questions, I'm happy to take those. I'm happy to take any criticisms, and like I said, it's sort of like a newer model that I'm developing, and I've been working with this data for a little while and start looking at some of these pathways, but yeah, thinking about what's next, and once we start filling in all these boxes on this framework and thinking about what's next, and what those interventions might actually look like. And there's still a lot of big question marks in this, and I'm sure there's a lot of factors that I'm not thinking about. And so if anyone has any general comments or thoughts or anything, I'm happy to.
Can you put the bottle back up there?
Oh yeah. Yeah.
I have a question.
Oh, I'll come here next. So this went up first. Go ahead.
Great job. I appreciate the complexity. It was about time that we look at this from many angles. And way to go, because there are many others. I have two observations speaking about complexity and prevention and intervention. We can't talk about obesity, especially starting early, which I appreciate you look at that, without looking at breastfeeding status for those kids. Breastfeeding or lack of it is very well known, metabolic determinant, either positive or lack of it. And I think you're going to find quite interesting findings there. If the data have that information, maybe for future.
Yeah.
And another component, equally critical, more even so, obesity. Besides diet, we have to look at energy expenditure, physical activity, and know that's a myth that all low income just sit in front of the couch. We have some of the best athletes in the world coming from those diverse neighborhoods, and that's what's going to guide you to prevention and solutions too.
Yeah, thank you. I think those are really great points, and yeah, definitely things I think about. And you're right, with the level of complexity is how to fit in all of these things in a way that my statistics can handle. But and thinking about, that also makes me think about just the context of adversity and some of the very prenatal and early childhood things and what's going on for the parent at that time. So thank you. Yeah.
Thank you for this really great talk. I love the integration and acknowledging the complexity of it, and looking across how different fields are maybe talking past each other to some extent. Just to add to that complexity and make everything even more, I figured I would add, I'm not sure you thought too much about this yet, but self-regulation obviously will have psychosocial determinants, and you alluded to some of the potentially biological or endocrine type determinants. But I think of things like omega-3 deficiency per se, that could drive alterations in leptin physiology and then cause people to eat even when their stomach is full. And it's not necessarily biologically wrong. It's the right thing to do because you don't have what you need. So we label it self-regulation, but actually maybe it's a different thing. So I just wanted to see if you had your thoughts on that.
Yeah, I think that the biological side of things is more of a question mark for me in my social work background, but I am actually someone I'm working with on this is a neurological specialist, so kind of help me think through just the alterations in brain changes and brain dynamics and all of that. But I didn't even think about nutrient composition and that sort of thing and how that can play a role. I think that's really interesting.
And I would just add to that, addiction, obesity is a disease, and so we often look at some of the prevention measures that lead to it, but treating it as a disease, and they have research out there that shows addiction, opioid and gun violence and obesity, and the intersection of all three is the brain science behind it.
Yeah, absolutely. When I think about the just relationship between ACEs and health outcomes, right? Obesity is one of them, but most of the ones that are talked about are other health conditions, the development of substance use and that sort of thing. That you see how these things relating to control and impulsivity and the same kinds of things kind of linked together. Yeah.
You use the word stress. What define it biologically? What's stress?
Stress, yeah.
No
The,
psychiatrist.
so the,
Just start,
yeah, so the way that like toxic stress or stress is when your body goes through or feels some even physiological and physical changes. It affects your cortisol levels and your release of cortisol. And so I think stress needs to, I'm not a biologist or, but so my understanding of it is that it depends on the level of exposure, right? So there's acute stress and there's chronic stress. And so our bodies are, developed to be able to respond to and adapt to some degree of stress, some level of acute stress, which is where we have our levels of cortisol that are released in the allostatic load. A chronic stress, though, is something that our bodies have not been adapted to deal with. And so when you have that over-release of cortisol and that over-activation of your stress system that your body's not prepared to do over time. And so the way I'm defining adversity in this context is when you're experiencing both acute and chronic forms of lower-level stress over time, is that your body is overreacting and over-responding, thinking that it's in this constant form of fight or flight. And that our bodies don't actually know how to adjust to these forms of acute and chronic stress that happen again and again over time, that can affect us biologically and physically, and drive our, it increases inflammation internally, increases our impulsivity and desire to want to control other things in the environment, things like that.
so all of that is true. How about just increased metabolic activity of the brain?
Mm-hmm.
The brain likes glucose.
Mm-hmm.
Food preferences shift to carbohydrates.
Yep.
They don't distribute just to the brain,
Right.
they distribute to the whole body.
Mm-hmm.
So as they go into storage,
Mm-hmm.
become released.
Right.
I'm familiar.
Mm-hmm.
So the biological determinants of stress, increased metabolic activity of the brain, can be sorted out. And one that I focus on is disruption of the light-dark cycle. We have all this artificial light that is impairing, it's not, everyone thinks about sleep, but it's darkness. And it's a simple intervention to turn the lights out, put the kids to bed on time, without flashlights, to read other comic books, like I do, and without their iPhones, and let us actually get quality sleep, which is anti-inflammatory and anabolic. The other thing that I think you should consider is that stress knocks down oxytocin. And oxytocin, the love hormone, is essential for development along the way. An intermittent disruption of oxytocin secretion is a high stress. And Ruth Feldman at Yale is a person that we...
Thank you.
All right. I have a question or comment or whatever. I work on the healthy food retail stuff here in Cleveland, and we model a lot of stuff from the Food Trust in Philly. And I was just wondering, in any of this, I know like with their new leadership and stuff, they're really looking at community-based and trauma-informed, and they're really taking a bigger approach at food and beyond the corner stores and farmers markets and school programming and all types of stuff. So I was just wondering if any of this they're involved, or it comes up as a indicator, as a programmer, and it's intervention as part of this work.
That's a really good point, because I haven't connected with them. I chatted with someone at the Food Trust a while ago. Yeah, and I think that was. I think we were. We were talking to them. Yeah, I didn't think I realized that they were starting to develop models around. And I was talking to them initially around like food redistribution models and community-based, partnering with community-based organizations. But I actually didn't know that they were trying to develop trauma-informed models. And
yeah, everything is their new leadership. Bill McKinney, he's really taking on a bigger approach to looking at
Yeah.
violence
Right.
and especially looking at like Kensington and just different
Okay.
areas. And
Yeah.
He's a Cleveland native.
yes.
Yeah.
Oh.
So that's why we're
Yeah.
friends.
I see.
So yeah, if you,
Right.
yeah, we can. Yeah.
I connect.
Yeah, that's
We've already-
right.
we've
That's
already
right.
connected, right?
You'll have to follow up with him.
Yeah.
Yeah, thank you.
Well, and likewise, too, to piggyback off of Brianna, we had Tufts University here doing the same causal loop diagram experience with early childhood around obesity prevention. And it's interesting, I was pulling up our CLD, our causal loop diagram, that our community developed through it. And ACEs and social emotional health and nutrition, we had 5 buckets of sort of cogs of the wheel that are all spinning at the same time. And the social emotional health and the nutrition, and then along with physical activity and parent and family engagement were all these big buckets.
Huh.
So I'd love to share that with you.
That'd be great.
Connect you with Chris Economos on that.
That'd be great, thank you.
Thank you for that presentation and for this model. It's really interesting. I think what I'm struggling with, and I have a background in child psychology now, more in the public health and doing a postdoc in the public health sector, that everything kind of ties back to this adversity dimension, which then like ties further back to like structural inequities and structural racism and things like that. So how that fits into our models or our interventions. So while we know like these little pieces and parts are important, people have adversity now. They need help buffering that so that they don't have that outcome of obesity or PTSD or whatever it is, which to me just seem like they're all outcomes of sort of this bigger structural issue.
Right.
So how that can tie not just into the model as something that's sort of like passively sitting there, but actually as like a really essential component.
Right.
And that to me is like, I mean, the complexity beyond that is so much, but I feel like it's always kind of subtly mentioned, like structural barriers, structural racism, but like how is it actually integrated into these models as well? So that would be an interesting thing to
Yeah, and I don't know if I'm doing this the right way, and I think about that stuff a lot, and ultimately I'm hoping that that's where answering some of the questions in here is going to lead to more system level interventions that are going to address the more structural things. And sort of my rationale for doing this way, especially saying adversity is not just trauma, adversity is hardship, adversity is, poverty, and the way that I think about it is more in the structural and systemic injustice types of ways. But when I try and talk about, I want to do interventions, around this issue, people say, you can't intervene on poverty, pick something else. And I'm like, but this is, right, but it's because of poverty. And I'm a social worker, and these are the things that are driving, this is why I developed these mediation models, because I'm trying to say that these are the things that are driving these behaviors. So we need to start our interventions not over here, but we need to start them over here. And then that's going to get us to the complexity of, well, where is the deprivation coming from? Where is the hardship coming from? How do we address that? And that's the macro level, the policy level implications that. So I guess it's sort of like my sneaky way of being like, let me give you some statistical evidence because, NIH and funders and science and intervention and program supporters love the evidence that say, well, we can't fix poverty, so, but adversity does get a lot of attention. The ACEs have gotten a lot of attention and finally gotten people in the medical field to say, oh, these are things that we should think about. These are things that we should be developing interventions around. And I want to establish evidence to get people to say the same thing, not just about ACEs, but about hardship, about deprivation, about poverty, that we need to intervene here. Once people start thinking about that, and the way that I think about it is that it's not like, well, go get more money. That's not the intervention. It's job development. It's workforce development. It's creating better structures in communities. And so I do think about that a lot. And this is my backwards way of trying to back up into it and find a way to say, here's some science behind why we need to think about this in a different way. So then we can back up and think about the systemic things. But there may be better ways to incorporate that early on and show that.
It seems like that box of childhood obesity risk could almost be replaced with infant mortality, with anything, with all these greater public health concerns.
Exactly.
So it's not saying that it's wrong. I think that it's a good model, but it's like, how do we get the attention
to the bigger picture?
To the bigger picture.
Exactly. Yeah.
Sorry, Elaine.
No, it's okay. So I would go the direction of the intervention space, because I don't disagree with any of this part, but I feel like if we don't sort of dig at ways in which to at least show that that needle might move. So talk a little bit about, like, I mean, the conversations we've been having is also is, okay, let's say we do still want to do a dietary focused intervention. How is it that we're not going to change the adversity, but how do we use the model to help us develop interventions that are we talk about these culturally sensitive interventions. Well, maybe culturally sensitive interventions now means trauma informed. Maybe it means all these things. And if those of you that came to last night we had dinner with Megan Holmes and Laura Voigt from the Trauma Center and had the same conversation with them. And if you remember me asking them, I said, well, how do I integrate trauma-informed approaches into these dietary? And their comment was sort of what yours is, which is more or less, but you really need to just focus on the adversity, because if you did that, you wouldn't have the outcomes. But that is true. But how could we also not continue to do these dietary interventions that are about goal setting and blah, blah, blah? You know, we all know an impact. We remove the barrier for transportation, right? We had a very high rate of engagement in the intervention. As we've said before, the families thought the intervention was very successful. They thought they had made significant changes in their lives. So what is it we could have done to help them? And maybe that's all that really matters, but the BMI didn't change of these overweight kids, right? So what I want to go back to the thing that you and I started on one of our conversations, which is how do we integrate social services into this, right? So you and I have talked about WIC and other kinds. Is there a way in which to do the systemic work in agencies that are already there? This is their thing, and it's not like we talk about. You can't really get them to do childhood obesity interventions, but how do we somehow bring these pieces together? That's one of my suggestions. I don't disagree with anything. I do agree that we all know that we have to figure out how to resolve, but I do think it's very helpful to know that different dimensions of adversity has different impact on child development. That's, to me, quite huge.
Right.
Because that suggests that you could do interventions that are specific. Maybe we need a precision intervention, instead of precision medicine, it's precision interventions that are made specifically on what folks are facing.
And I think, sort of like we were talking about earlier, getting at the system level things, like one of the first steps will be doing some qualitative work with families to start, to say, instead of all these things that we have defined for you that we say are adverse, but to say, what are these kind of daily stressors, what are the adversities that you see? And also, at the kind of system level, like what community supports are you using? What social service agencies are, supporting some of these efforts and some of these risk factors, or even what sorts of community supports do you draw on that, help you kind of get by and deal with some of these adversities? Or, are there any, are there none? Is that going to be maybe a part of like developing organization capacity to address these things and provide supports in a different way? And when I think about, working with WIC, where it's, families who are low income, nutritional risk, in the right age group, and they do some nutrition education and, food support, nutrition support, but they don't do a whole lot of, support around adversity or, other types of stressors that families experience, and other ways that we can start building out these community programs to be more supportive. Do you have a comment?
Oh, I was just going to ask, because you previously mentioned, I was going to ask if you were going to do that qualitative work, because you
Yeah.
mentioned that previous kind of lists of these ACEs are a priority instead of emergent.
Right. Yeah. So my first step is to be a mixed methods study to test this, and I'll start with some of the qualitative work to try and see which of these, because there's a lot of different bits of adversity, and I think some of them might map onto certain health outcomes versus others. So which ones are really most important for obesity prevention and dietary risk and sort of like day-to-day stressors?
Can we talk about one more thing, which we've kind of egged around, but this whole notion that the same model applies to the parent as it does to the parenting skill, or to the child long term, but like this whole notion of the interventions for 2 to 5-year-olds is really the parent, but the parents fit into this model equally.
Right.
And so how do you, like...
That was actually partly my question is, we're looking at individual factors of the individual's impact their threat, their deprivation, how that impacts their self-regulation, all that stuff. But when you're talking about 2 to 5-year-olds, that obesity risk really comes from family patterns, family dietary choices, a family structure, which is a different level than those individual factors. So I was just curious as to how you were addressing that in your modeling.
Yeah, so I think that those are both. I think those are both important. And I think like the family dynamics and the parent level effects and food parenting, especially at this age range, are really important. And so, you know, some of the other research that I've done have really been around like parent-child dynamics and parent-child relationships and mealtime structure, mealtime patterns within the home. Really looking at like the family system as a whole. And I mean, it's not here in this model, but I do think that that's an important component. With this, I'm kind of driven to, you know, where I think that that's important. We know that plays a role. I'm more interested in adding on to that, like how does this affect the early development of child self-regulation? Because we also know that parent-child relations is not just about the parent, and it's not just about the child, it's also about the parent-child relationship. And children develop based on the quality of that relationship and, you know, temperament and internalizing and externalizing behaviors. And, you know, for this next study where I'm going to look at this role where, you know, I think we have a good sense that that's important. And I do think that would probably kind of come into play in this middle here where we're looking at the, you know, the development of between adversity, where parents can be definitely a protective factor between adversity and development, or they can be a risk factor. And I do think that plays an important role. Some of the limitations of research and trying to develop models that you can actually test statistically, or that my statistician says you're turning this into spaghetti and meatballs because there's too many lines going everywhere. But yeah, I do think that is a really important thing. And I mean, really, this whole model should be laid into your ecological model, because there's the community level effects, there's the household level effects, there's the individual child dynamics, there's the individual parent dynamics, and all of them are going to interact. That's how my dissertation became also a chicken soup.
Yeah, I guess,
yeah.
All right, you guys, that's sort of the end of it. One comment before we say thank you, I want to just, let me say this real quick. So when meeting Megan and Laura last night, they wanted just to remind, this is the Center for Trauma, what's it called, right? It's Trauma and Adversity at MSAS. They're having October 5th is an Addressing Indirect Trauma by Caring for Caregivers. There is a cost, but if there are folks related to the center that would like to attend, let me know. And these are sitting out on the table, okay? But now, without further, we can say thank you so much.
Thank you.
This is awesome. I think we're going to hear a lot more. This is the work I think a lot of us. I like the comment somebody just made, which is it doesn't just obesity is not the only outcome. Right. This is a.
It'd be interesting to talk with Margaret Mitchell as well, because the YWCA in Cleveland is a trauma-informed childcare center. So I'm wondering. And then Ohio Guidestone is another organization we've been working with early ages, healthy stages to address. They've got some social service work on ACEs, because we have Dr. Nadine Burke-Harris here.
Oh, wow, yeah.
All right.